Good afternoon and welcome to our Engaging Faith-Based Organizations in Your Community Peer Learning Call. I am Selena Webster-Bass, CEO of Voices Institute, a core partner with the Children's Behavioral Health, Cultural and Linguistic Competency Technical Assistance Team, and also Cultural Competency Educator with the Jacksonville System of Care Initiative in Jacksonville, Florida. I am delighted today to be joined by two co-presenters that will discuss collaborative efforts between the faith community and behavioral health organizations in their local communities. Our co-presenters are David McClung of Texas System of Care and John Katoff with Open Table. And I'd like to give them each an opportunity to briefly introduce themselves.
Hi, my name is David McClung. I'm the Youth Engagement Specialist at Texas System of Care out of Austin, Texas, and a PhD student at the Diana R. Garland School of Social Work at Baylor University, where I'm researching the role of congregations in mental health.
Good morning. This is John Katoff from Open Table. We are a poverty transformation model that partners faith and government together to create a co-investment in people who are developing their lives. We partner with systems of care in 5 states, bringing faith and government together as people transition out of systems of care into the community. This partnership provides a support system to help people sink roots and develop sustainability in their lives. SAMHSA is an encourager and supporter. They've invested to help us develop a training system, and which has now been translated into the Spanish language. And look forward to talking to you more about this model later on in this webinar.
Thank you so much, John. Unfortunately, Anne-Marie Sheffield wasn't able to join us because of the weather conditions in Florida, so we're sending lots of warm thoughts her way. So the Peer Learning Exchange is hosted by the University of South Florida, College of Community and Behavioral Science, Department of Child and Family Studies, a partner in the National Technical Assistance Network for Children's Behavioral Health, operated by and coordinated through the University of Maryland. And just to let our listeners know, the PowerPoint will be available at the end of the presentation. Our goal today is to discuss faith, spirituality, and religion as a source of natural support for children, youth, and families living with behavioral health challenges. We will also identify barriers and solutions in building a bridge between behavioral health providers and the faith community. And finally, we'll discuss approaches that communities may use to engage faith and behavioral health communities in addressing mental health literacy, poverty, social support, cultural competency, and service delivery. Oftentimes, the terms spirituality, faith, and religion are used interchangeably. We would like to define each of the terms along with faith community and providers. Religion is an organized system of beliefs, practices, rituals, and symbols designed to facilitate closeness to the sacred or transcendent, God, a higher power, and ultimate truth or reality. Spirituality is a personal quest for understanding answers to the ultimate questions about life, about meaning, and about relationship with the sacred. Both spirituality and religion involve belief systems and have commonalities. They prescribe values, they guide individual behavior, and how we interact with ourselves, with others, and the world around us. Religion is an adherence to rules. It's very structured, it's rigid, it's formal, it's organized, they're established symbols, and religion tends to have a public aspect. Spirituality, on the other hand, has a private aspect. When we refer to faith, we're speaking of trust, belief in something, someone greater outside of oneself. It involves a great sense of devotion and does not require empirical evidence. Faith community refers to a cluster of people connected with a religious and or spiritual group. And when we refer to providers, we're referring to behavioral health, primary care, mental health providers, and human service professionals that work directly with children, youth, and families to improve physical, social, and emotional well-being. So the goal of cultural competency is to advance health equity, improve quality, and help eliminate health disparities. And we know that some health disparities may be associated with the cultural beliefs of individuals and their families. The Department of Health and Human Services Office of Minority Health has identified the National Culturally and Linguistically Appropriate Services, or CLAS standards, as a blueprint for addressing health disparities in health inequity. In 2012, the national class standards were updated and the definition of culture was expanded to other categories beyond race and ethnicity to include socioeconomic status, geographical differences, sexual orientation, gender expression, identity, immigrant status, and yes, religion and spirituality. Because effective, quality, and respectful services must take into account children's and caregivers' belief systems about coping with mental illness, beliefs about mental illness causation, and religion and spirituality as a source of social support. Certainly our families are not one-dimensional. They are multidimensional, and a number of factors influence and impact the well-being of children, youth, and families. I currently work with our wraparound coordinators. Wraparound is a systematic care coordination process for families living with severe mental health challenges. And when the parent coordinator or the wraparound coordinator conducts the cultural assessment with the family and with the youth, they will ask, is faith, religion, or spirituality important to you? And oftentimes our families say yes. And then we further probe by asking, are there religious or spiritual activities or resources that we may include in your care plan to help you? We've had youth to tell us that my youth pastor is someone I really trust, someone who's important to me, and I would like her to be a part of my wraparound team. Or we've had families that were not initially comfortable having meetings in their homes, but rather preferred to convene their wraparound meetings at their local church, their synagogue or mosque, a safe space that was identified by the family. We've had families tell us that they'd like to include spending time together as a family with their faith community as a goal under the family and social domains category in establishing family traditions, rituals, and connectedness. Demographically, the U.S. Census Bureau does not ask about religion and spirituality. There are no governmental statistics on the religious composition of the U.S. public that is collected by the federal government. So the Pew Research Center for Religion and Public Life fills that gap by conducting a telephone survey with over 35,000 people across the U.S. from all 50 states about their religious affiliation practices and views. So the Pew Research Center for Religious and Public Life conducted a study, and as you can see in this slide, in the age range of 18 to 29, that 67% of adults said that they were affiliated with an organized religion. And the percentage of affiliation increases with age. In the most recent Pew Research Center study, it showed that 70.6% of adults, that's about 173 million adults, identified as Christian, about 5.9% identified with non-Christian faith, about 22.8% identified as unaffiliated, and 0.6% did not know or were confused. This data indicates that since 2007, there has been a decrease in individuals identifying as Christian, mainly in the Catholicism category, and slight increases in individuals identifying with non-Christian faith and unaffiliated groups. In the 2014 Pew Research Center for Religious and Public Life survey, 54% of adults responded that religion was very important in their everyday living, and 24% said that religion was somewhat important in their everyday living. Religion plays an important factor for many children and teens and is positively associated with aspects of child well-being. Religious teens are more likely than their non-religious peers to engage in healthy behaviors such as exercising regularly, wearing a seatbelt, and having healthier eating and sleeping habits. Teens who report that religion is very important to them are less likely to engage in violent behavior towards peers or teachers. In this slide, the Child Trends Monitoring the Future 2012 study conducted by University of Michigan shows that a higher percentage or a higher proportion of female students than male students report that religion is very important in their lives. The next graph shows the role of religion in youth lives from 1976 through 2012 for selected years. The data shows that during the 1990s, the percentage of students reporting that religion plays a very important part in their lives generally increased among all grades studied. From 2000 to 2010, there was a decrease across all grade levels. The graph shows consistently that a greater share of middle school students, 8th graders, reported religion playing an important role in their lives. So it's important to remember that culture is complex and dynamic, and that cultural and religious groups may impact beliefs about mental illness and health-seeking behaviors for various racial and ethnic groups. Faith, religion, and spirituality impact health-seeking behaviors, and we need strategies among providers in the faith community in terms of integrating behavioral health and faith outreach to promote well-being. Here we see that culture also impacts worldviews of various cultural groups. For example, in Native American culture, health is cultivated through balance and living in accord with nature and the community. The view of health is holistic, integrating the physical, emotional, and spiritual elements, and oftentimes traditional healing practices may be used to address behavioral health. For many African American families, there is a reliance on what I call the 3 F's: friends, family, and faith, and several studies to confirm that African American churches and clergy are frequent sources of socio-emotional support for African American families. Faith communities have a primary and influential role in African American communities, encompassing a broad range of issues, including historically civic, political, education, economic, and community development, including health and well-being of individuals and families. Historically, African American churches have provided a wide range of resources and opportunities that were inaccessible to African Americans from mainstream institutions. And so the literature shows us that clergy play a critical role in helping African American congregants with problems and are consulted for a variety of issues, including mental health issues. And oftentimes these clergy function as gatekeepers to mental health services. But there are advantages and disadvantages. Advantages include that for many families, there is no charge, there are no co-payment. They're able to approach clergy directly. Clergy will come to their homes, and there's a long-standing, trusted personal relationship with congregants. Disadvantages are that clergy are sometimes a heterogeneous group that may not have specialized training or licenses in counseling. And so we have to ask those critical questions: are clergy trained, and do they have the ability to identify serious mental health problems And do they know when to refer, where to refer, and referring procedures? So hence, there's this need for faith-based organizations to partner with systems of care and behavioral health organizations to provide community education and referral resources in meeting the needs of families. We also see similar patterns in the Hispanic and Latinx community. The faith community oftentimes is the first point of contact for mental health support. First-generation immigrants may use curanderos or traditional healers for behavioral health services. And also we see in our second-generation immigrants that there may be a preference for primary care providers in receiving mental health services versus going to a psychiatrist because of the stigma that may be associated going to a psychiatrist. For the Asian American and Pacific Islander, we see again that integration of physical, mental, spiritual, and emotional health. There's also an emphasis on harmony and balance. Traditional healers and oftentimes herbal preparations may be used in dealing with mental health issues. The literature indicates that there are some risk factors associated with people who are affiliated with religion. Some religious groups have been linked with hysteria, neurosis, and psychotic disorders. And also religious individuals may not seek needed services because their belief system says that to have a mental illness is considered personal weakness. But there are those protective factors. Religious beliefs and practices can be powerful sources of hope, of comfort, particularly with substance abuse treatment. And religiosity may be a protective factor against substance abuse or substance use in young people. Teens who report religion is very important or pretty important in their lives are less likely to have been in trouble with the police in the past 12 months, to have used hard drugs, to have been offered drugs at school, and to have sold drugs, to steal, to vandalize property. So the list goes on. And teens who report religion is at least a little important are less likely to shoplift or to skip school, and they are more likely to participate in community volunteer activities. And there are many explanations in the literature for these associations, including family religiosity, peer groups, the selection of peer groups, and the congruence of religious teachings with personal moral beliefs. Some of the barriers in engaging faith organizations and behavioral health providers include providers sometimes are uncomfortable talking about religion and faith because it's not considered evidence-based, it's metaphysical. But faith and religion are important components of many of our youth and families' cultural identities. And it's important that behavioral health providers conduct that self-assessment and confront any negative assumptions or generalizations that may exist specific to youth and families with religious and spiritual orientations. And so there needs to be a focus on empathy-building skills and ways to integrate unharmful cultural practices into care plans. An example of that is the FICA tool, which was developed by Dr. Pachaska. The FICA, F stands for faith and belief, I stands for importance and influence, C for community, A for application. This is a spiritual assessment tool that providers can use in terms of eliciting information from youth, from families, to understand ways to integrate spirituality into care plans. Other barriers that exist is a lack of the understanding of the significance of spirituality and religion for various cultural groups. And so professional learning opportunities and inviting gatekeepers and faith leaders to behavioral health agencies to have conversations, courageous conversations about faith and the integration with behavioral health is really important. Another barrier specifically that we see with the faith community is stigma. So engaging faith leaders and organizations in mental health literacy programs and creating referral networks between faith organizations and behavioral health providers is an important strategy in terms of addressing this issue. Okay. So this is the FICA tool that I mentioned, the questions here, faith, do you consider yourself to be a religious or spiritual person? These are questions that can be directed to the youth or to the family or caregiver. How important is spirituality or religion for you? Are you part of a religious or spiritual community? So is there someone that could possibly be a part of the natural support network to help this family, particularly after services have ended, that can continue to support the family? And how would you like to address spirituality and religion in your care plan? But clearly the message that we need to hear both from faith community and behavioral health providers is that recovery is possible. So we'd like to go into our community examples now. I'm going to start off. I'm going to put on my cultural competency educator hat now with Jacksonville System of Care Initiative and discuss some of our programming that we conducted since 2012 specific to faith-based outreach. I'll be followed by David and then John Katoff with the Open Table. So in 2010, our community, Jacksonville, Florida, we received a system of care implementation grant focused on creating a transformative system of care for children and youth that were involved in juvenile justice, foster care, and homeless systems. In 2012, we initiated a diverse and robust CLC committee, and this committee was comprised of representation from public schools, behavioral health, juvenile justice, foster care, child welfare, law enforcement, faith community, as well as members from our Federation of Families chapter and our Youth Move chapters. And our goal was to address health inequities and disparities through professional learning, community education, and outreach and assessment. So based on our local youth risk behavior survey data, we had lots of community discussions, and we decided that we wanted to focus on 4 core areas. So we developed 4 subcommittees under our Cultural and Linguistic Competency Committee. Our Refugee Immigrant Population Committee, our Hispanic Latinx Committee, an LGBTQ I2S Committee, and a faith-based committee, which was initially focused on African American faith-based outreach, but we later broadened our focus to include other multicultural faith organizations as well. And we named that faith-based committee Healthy Minds, Healthy Hearts. So we begin with sharing data with faith leaders from our 2013 Youth Risk Behavior Survey, and we saw that there were major disproportionalities in terms of student-reported depression and suicidal ideation. We decided to really focus on community education with faith leaders and with caregivers. And so our first event was an integration of faith and behavioral health conference. We brought in Dr. Gloria Morrow, a psychologist out of California who has a strong research interest in faith and behavioral health. We included an interfaith panel to discuss mental illness from various religious traditions. We also included a youth from our Youth Move chapter that was living with bipolar depression, who talked about how she embraced both prayer and meditation, but also had a wonderful relationship with her therapist and her psychiatrist. We had over 100 participants, both behavioral health providers, faith leaders, and also youth and families. And we had very honest discussion about stigma. The lack of referral networks was something that really resonated throughout the conference, and also this bridge that needed to be built between faith leaders and the behavioral health community. Other trainings that we offered were question, persuade, refer training. We offered that training in partnership with our Duval County Public School System. We had over 100 participants at that training. And we also offered youth mental health first aid training for faith-based partners, as well as adult mental health first aid training for our faith-based partners. And to date, we have partnered with over 50 faith organizations and trained over 500 faith leaders and congregants in our community. And we've seen an increase in our pre and post survey results. And we've also developed a referral guide for our faith leaders to use in referring their congregants to various behavioral health agencies in our community. So we're very excited about the work that Healthy Minds, Healthy Hearts has accomplished. Some of the strategies that we use in terms of working with faith-based organizations is that most of the time, yes, we started with the pastor or the imam or the rabbi, but we sometimes found that we were more successful by working more closely with the pastor's wives or their partners, working with the ministry healthcare leaders, working with youth pastors and family organizations. So working more so with the ministries that many of the churches and faith organizations had already developed. We've made much more progress in terms of coordinating trainings and education with the congregants. We also leverage existing interfaith networks in our city. We currently have a group called We Care. It's a social justice interfaith group. They've been doing lots of advocacy work specific to civil citations and juvenile justice. And so we met with that group several times. And so a lot of our faith-based leaders that were part of our committee and a lot of our trainings were offered at churches that were a part of this interfaith network. We identified community champions, and what we found is that typically these community champions were faith leaders that had more formal education. They were leaders that had extensive networks already established in the community. Typically these champions had large congregation sizes of 500 or more congregants, and so there were financial resources in place where they had full-time paid staff to coordinate activities and so forth. But we also didn't want to leave out our smaller faith organizations such as storefront churches and some of our mosques and so forth. So we also conducted trainings at those locations as well, but we wanted to maximize the opportunity with larger faith-based organizations. We made sure that our mental health outreach goals were in alignment with the mission and vision of the healthcare ministries that we're working with. And then it was lots of planning, lots of communication going back and forth, and then also making sure that we had our pre and post surveys as well as follow-up information specific to referral networks. And so we're working with University of North Florida to do 9 and 12-month follow-up surveys with individuals that participate in the training to determine the number of referrals and so forth. This is the last year of our system of care implementation grant. We did receive an expansion grant, but of course it's not for as much funding. And so a lot of our faith-based outreach work is being sustained by other community partners, which is really exciting. Our community received a Project Aware grant, which is to fund youth mental health first aid trainings in our community. So a large number of those trainings are targeted specifically to the faith community. One of our local hospitals, Baptist Health, has taken over the Faith and Mental Health Conference, and so it's an annual event that's held. The resource guide is a highlight for the faith leaders because that resource guide is updated every year. We also are working with our historically Black college and university, Edward Waters College, by supporting their annual Black Family and Mental Health Conference. And the last day of the conference, there's a session called Mental Health in the Ministry. And so we oftentimes provide the speaker and coordination for that session. All of the not-for-profit hospitals have formed a partnership in our city, and one of their goals is to train 10,000 people in adult mental health first aid over the next 2 years. And so we just had our first class of adult mental health first aiders trained. And so again, faith-based outreach is a key component of that partnership. And so we are developing, additional lists in terms of who we'd like to target in terms of making sure that we're not just doing the youth mental health first aid, but also addressing the needs of caregivers, the adult population as well. And then we keep communication going through our quarterly newsletter. It's called Healthy Minds, Healthy Hearts. We highlight faith-based organizations as well as, much of the cultural competency work that we're doing in the community in terms of professional learning, organizational assessment, and community education and outreach. All right, so I'll turn it over to David to discuss mental health literacy and pastoral care practices. Thank you.
Thank you so much, Selena. So again, my name is David McClung. I'm the Youth Engagement Specialist at Texas System of Care and a PhD student at Baylor University, where I am researching the role of congregations in mental health. And so this is a topic that's important to me as a professional and as a researcher, as a person of lived experience myself, and then also a ordained minister in my own faith tradition. And so today I want to talk to you about mental health literacy and pastoral care practices of youth ministers. And so in doing so, again, I think this is an important conversation. And as Selena mentioned, there begins to be this question of what do ministers really know about mental health, and where do they have that knowledge from? How have they gained that information? And not only how have they gained that information, but then how have they used that information for practice? So as Selena mentioned, are they able to identify mental health diagnoses? If a youth or a person comes into their office with a mental health challenge, do they recognize that as a mental health challenge? Or do they recognize that as something else and identify that as something else? And then in response to how they diagnose that, or rather how they assess that situation, what do they do with that information in response? So do they make a referral? And if they make a referral, what kind of referral do they make? How do they decide whether to make a referral? And who do they make that referral to? And so these are each components of mental health literacy. And mental health literacy, again, is kind of a broad term that's used to describe the knowledge and information and skill acquisition that's used in understanding and navigating mental health services for one's self or for somebody else at the same time. And so in thinking about that then, there begins to be a question in general of why is this conversation important, that we're thinking about the role of youth ministers or the role of congregations in mental health. And so in beginning to think about that, I want to go back and review some of the information about youth mental health in general. And hopefully some of this looks fairly familiar. And so the World Mental Health Survey collected data from 16 different countries and found that out of those, roughly 50% of the mental health issues really begin by age 14. And so the National Comorbidity Survey also looked at those ages with 10,135 youth in the United States, and they found similar ages. So a median age of anxiety disorders beginning was age 6, mood disorders age 13, substance use challenges or use beginning at the age of 15. In addition, 40% of adolescents with a mental health diagnosis in this National Comorbidity Survey also met the criterion for a disorder in another class. And so what that tells us is that the numbers of youth who have these mental health challenges is rather large, and there's a significant population then with these needs, and congregations may serve as an outlet for that, for helping to meet and support some of those meeting of those needs. But furthermore, not only are these needs present, but treatment options may not always be set or sought at the point of onset. So for example, a study with patient advocates in the United States and Canada reported that 40% of those who were surveyed sought treatment in the first year. And that number may seem fairly large. 40% sought treatment and they began to seek help or assistance and support for those challenges. But the other 60% waited a median of 8 years before receiving services. And a lot can happen in a year. And so if a lot can happen in 1 year, a whole lot can happen, and a whole lot can change within a period of 8 years. And so the question is, how do we make sure that at that point of onset, that when there begin to be concerns or when there begin to be questions about mental health or when there begin to be differences in behavior or sleep patterns or eating behaviors, that people feel like there's a level of comfort or there's a level of accessibility to be able to seek those supports and services rather than having to wait that median of 8 years until either that need is so great or there's a felt acceptance for being able to seek those supports and treatment options. And so when services are received, they may be done through a number of different systems other than the mental health system. So for example, 65 to 70% of youth that come into contact with the juvenile justice system here in Texas have a diagnosable mental health disorder. And so while some youth may be able to originally seek treatment options or services and supports within the context of a community-based mental health center, often some of these concerns really aren't identified or even addressed or talked about until youth are in different situations and in contact with other systems as well, including the juvenile justice system, foster care systems. Maybe they're aging or transitioning out of services. And these are where these concerns begin to have more notice, but also more impact in terms of what those mean in trying to make those transitions during those points in life. And so the question becomes, well, why is there this wait? What is there that causes for people to not seek services and supports when these questions first begin to form or when these changes in behavior are noticed? And one of these reasons may be mental health stigma or a prejudice towards individuals who have a mental health concern or condition. And so there's, for example, mental health conditions may sometimes be viewed as personal responsibility, and there may occasionally be this attitude of if you have a mental health concern, that's really your business, and that's your responsibility to seek services and supports, and nobody else should be responsible for that. And that kind of attitude and belief system or that prejudice towards individuals may begin to grow, and those beliefs come to have a negative impact. And so, for example, in Texas, we find that there's an average annual amount of about $13.24 per child or adolescent for community-based mental health services, which clearly really isn't a very large amount considering the needs and statistics or numbers mentioned in the previous slides. And in addition, this kind of stigma and some of these beliefs, again, may translate into other types of behaviors as well. And so, for example, in a qualitative study of adolescents in the Midwestern United States, 62% of participants who were youth reported experiencing stigma from their peers, and 20% reported being socially isolated, unable, or unmotivated to forge meaningful relationships with peers. And so what that does is that leaves these youth who have real concerns, real questions, real things that are going on in their lives and their relationships, in their daily routines, feeling like there really isn't somebody who they can reach out to, somebody who they can really find support from, somebody who can really try to at least say, hey, it gets better, or hey, I know this other person who went through a similar experience, and you're not alone, and you're not the only person who is experiencing whatever you may be going through at this time. And similarly, congregations may sometimes have similar beliefs and similar understandings of mental health. So congregations may sometimes, for example, interpret mental health to be a result of sin or a demonic possession or a lack of faith. And as a result, believe psychological theories or practices to be counter to Scripture. And so one particular quote that I found that I think adequately captures the harm and sort of the belief systems that congregations may occasionally have comes from Dr. Powlison. And in 2001 in his book, Dr. Powlison says, quote, "A preacher no more needs a PhD in public speaking than a counselor needs a PhD in psychology. Graduates of psychology programs should not have the right and honor to teach the church about the human condition. They have wrong knowledge, the wrong credentials, the wrong financial and professional structure. And so I'll let that sink in for just a second. And so there begins to be a question then, if you have a minister or you have somebody that comes from your faith tradition who congregants in those congregations may see as somebody who is thought to be reliable, thought to have good information, thought to have connections to referral sources, thought to have an understanding of mental health, and is trusted by that congregation member and that congregation's natural support systems. And somebody from that faith tradition says, hey, what you're experiencing really isn't what you think you're experiencing. And this really isn't what's happening. Maybe what's happening is really just a result of something that you've asked to be brought on or that you've brought on yourself. What does that feel like? And what does that feel like then when there's a divide, when you're trying to seek support from a minister who you trust, a minister who in many ways serves as a natural support system and is able to serve as a natural support system, but also wanting to be connected to the rest of the community and wanting to be able to receive those additional supports. And I want to suggest that that feeling is one of, again, of isolation, that once again we can find sort of a divide where individuals may feel split of, do I go to my faith leader, do I go to that clergy member and continue to trust that they have that information, or do I access services against that clergy member's will in fear that minister may find out? And if that minister does find out, do they confront me on that? Do they allow for me to feel like I can still continue to go to that congregation? And if not, then what do I do in response to that? And so again, we find that these belief systems may again impact our practice as well. And negative experiences in the church such as that aren't uncommon. So an online survey conducted by Dr. Matthew Stanford down in Houston was done with 293 Christians who sought counseling from the church. And out of those 293, in this online survey, 30% reported a negative interaction. 31.4% reported that the church made them feel like mental illness was a result of personal sin. 32.4% reported that the church suggested they didn't actually have a mental illness. 36% stated their faith was weakened. And 12.6% reported leaving their church. And those last two numbers in particular are numbers that I continue to return back to. What does it say when you have developed a sense of an ownership of your beliefs, and then that faith is weakened because you sought assistance from somebody you thought you could trust, and that faith is weakened as a result? Or what does it say when, again, people leave their faith, they leave those natural support systems and those relationships that they have become used to and accustomed to depending on? And how are those natural support systems replaced? How do you develop additional relationships after that? And what does that look like in terms of trying to reconstruct a belief system, but also reconstructing some of that social capital or those social relationships that are used to inform how you live in the way that you live? And so at the same time, I don't want to just paint a negative image of congregations. Congregations, in fact, are full of natural support systems and have been shown to be adept at providing response to crisis by doing things like providing meals, making hospital visits, and lending listening ears. Congregations may often have a number of individuals, again, who, like those outside of that congregation, have experienced mental health concerns, and who can provide sort of that peer perspective of, this is what it was like, and this is how I got through these times. And again, hey, you're not alone, and it does get better. And faith, in fact, has been an important part of individuals like Dorothy Day or Jane Addams, as well as founders of other parachurch and religiously affiliated organizations. The question is, if congregations have these resources, if congregations have this social capital or financial capital and other forms and types of resources that are able to be used to assist people with mental health concerns, how do they do so? And I want to suggest that one of the reasons why congregations may not always do so is because they don't realize the need is there. And so in 2012, Rogers, Stanford, and Garland conducted a study with 24 congregations. And in doing so, they asked families to rank 45 different congregational priorities. So they gave these congregations a list of 45 items. And they said to these families, will you please rank these in order of which of these you find to be most important? And families that weren't affected by mental illness or mental health concerns ranked mental illness as being the 42nd of 45 congregational priorities. Meanwhile, families who were affected by a mental health concern ranked mental health as their second priority. And so you see a divide there where those who are affected by mental health say, hey, this is something our congregation, our church family, our membership, our natural support system really needs to be talking about. And not only do we need to be talking about it, but we need to be having conversations about how we can utilize our resources to meet these needs. And those who weren't affected by it maybe didn't recognize the need. And because they didn't recognize the need, they rated it as a lower priority. And so, again, we find that congregations are in this strategic position. But ministers who work with youth and clergy who work with youth are in a similar strategic position for addressing the complex needs of youth and families. So, for example, youth ministers may show up at schools, they may be there for lunch times, they may go to camps, they may show up at football games, they may spend a large amount of time with these youth if those youth and their families are actively involved in congregations. And as such, they have a unique opportunity to invest in those relationships and are naturally dedicated to making sure that those youth are in safe, secure environments that can help to work towards the total well-being and health holistically for those youth and with those youth, more importantly. And so again, in the National Comorbidity Survey, 25% of individuals reported seeking mental health treatment from a clergy member, which was also more than those who reported seeking treatment from a psychiatrist or a general medical doctor. And so the question is not whether individuals go to clergy for mental health concerns. The question is if they're going to clergy, if 25% of individuals are going to clergy for a mental health concern, then again, what is that mental health person doing? Or what is that clergy member doing in response to the help that's being sought? And it's also important to note then that the majority of those who sought help from a clergy member actually didn't seek help from a mental health professional. And so that's a little bit concerning if we recognize mental health professionals to have the knowledge needed and the skills needed to help those with mental health concerns, because it tells us that individuals are going to mental health professional, or they're going to clergy, and that it's stopping at that point. There's not a referral being made. And so there begins to be this question of, well, what are they doing? And what kinds of knowledge do they have to try to make those decisions? And so in a survey of 70 North American seminaries, 7% of the seminaries required one or no classes in counseling to complete a Master of Divinity, which is normally sort of a standard degree for clergy members and a pretty wide array of religious traditions to practice. Furthermore, 12% of those seminaries didn't address mental health in any form. And so what that tells us then is we have clergy who are working with individuals with mental health concerns, but may not have any information on what to do with those concerns or how to identify those concerns. And as a result, clergy may feel like they don't have the skills needed So in a study of Protestant ministers in Hawaii, 79% of respondents reported feeling that their training in mental health was inadequate. And again, that often may result in a lack of referrals. So a 2007 study of 51 congregations found that 62.5% of the surveyed clergy made referrals less than 10% of the time or right at 10% of the time. So if they're not making referrals, clergy may not have the training needed. They recognize they don't have the training needed. Then I think the question begins to be, what are they doing? What are clergy doing when these concerns are presented to them? And unfortunately, I don't know that there's a lot of clear information or a lot of clear answer to that. One of the only studies that I found, and if you know of additional resources, please feel free to write these to me. One of the only real answers that I found to this came from Hunter and, again, Dr. Matthew Stanford in 2014, when Baylor researchers conducted a survey with 347 college and youth ministers in Texas, and asked that question again of, when you're meeting with individuals who have a mental health concern, what are the types of activities that you're doing? And out of that, 20% reported using biblical counseling or pastoral care, 22% reported making referrals after the initial visit, 15% reported providing counseling, primarily with psychological concepts, 14% gave general support, 11% set up a Bible study of peer groups, and 10% included the rest of the family. 8% prayed or did not take any active steps. And so one of the things that is interesting to me is a lot of these numbers are rather low. And so if 20% are providing biblical counseling and pastoral care, for instance, there's overlap in these numbers. And some of these activities may have been used by multiple clergy, or individual clergy may use several techniques or activities within their practice. But the numbers are low enough that the overlap doesn't necessarily suggest a very clear understanding or a very clear picture of what's happening. And so what that suggests overall is that there's a need for additional dialogue. There's a need for training with mental health professionals. For how to connect with clergy and congregations. There's a need for clergy and congregations to know how they can best support those within their congregation and those within their community who have mental health concerns. And that dialogue can be difficult to have because on one hand, having those conversations takes a level of courage. It takes a level of vulnerability to be able to say, you know what, I may not know much about congregations if you're a mental health professional. Or as a clergy member to be able to say, you know what, I may not know much about mental health. And being able to acknowledge that lack of information is necessary for that conversation to often take place. And so that's just some general information about what we know of those practices as well as what we know of the role, really a powerful role, that congregations and ministers may be able to play in connecting with mental health professionals to ensure that those services individuals receive are well coordinated, one, but also that they're culturally competent, and that those referrals are really taking place to meet the needs of congregants in their communities. And so I'd like to turn this over to John for the moment now to talk about Open Table as one model that also helps to do that.
Thank you, David. Thank you, everybody, for giving your time to hear about this model and the story behind it. Excuse me. I think in Open Table we believe that the first thing that we say in any faith government gathering is that we're all invited to speak from our own beliefs and that we will all respect the beliefs of all others gathered. About 4 years ago, I had a call from Denise Salzbach from University of Maryland and the TA Network. She said that she thought faith was important in the transformational process of human beings. She invited us out to the University of Maryland to present Open Table, and the TA Network has provided or is providing now significant support to the development of this model. And Gary Blau and his team are providing a vision for a redefined faith-government partnership and the support to develop tools that are based on evidence that can be used by the community to co-invest in the clinical support that systems of care provide and to create a long-term extension of the system of care into the community so that people can become integrated and can begin to live into the potential that they define for themselves. Anne-Marie Sheffield could not attend today. She's the project director for Wraparound Orange, part of Orange County System of Care initiative. Shortly before the call, Anne-Marie was called, as were all county employees, to special preparation for the hurricane. So prayers for her and her team. Orange County was one of the first 3 systems of care selected by SAMHSA to really be a demonstration site for this new vision of the faith-government partnership and the extension of the investment that the federal government and counties make in systems of care into the community to build a bridge for people coming out of wraparound support to the support of the community. I think it's probably obvious to all of us to see the great and powerful investment made in people through systems, but the lack of the presence of the community at the other end as people transition out, especially our transitioning age young adults. And that's what I'd like to address today. I guess I'd like to talk to you a little bit about how OpenTable started so that you can see the transition that was made really from a community movement into a model that could begin to link with government. The short story is that our local mission trip to the homeless shelter was focused on the handing out of energy bars and sandwiches and apples and water to some of the 400 men who were residents there. I think after quite a long time, we actually realized that 32 grams of fiber in an energy bar does not overcome poverty. Simultaneously, a man came out of that shelter one day and asked if he could worship at our congregation. When he came up to our congregation, our congregation members fell into deep friendship with him. But I think that for community members, and I'll say a national community that is sheltered, truly sheltered from the pain people in poverty or with mental illness challenges face, especially the emergency of our young adults, we experienced a desire for the same deep friendship with us from him and the other people that we started to serve. Please understand that the faith community does an incredible job of teaching people to give money, give time, give things that you don't want anymore, but teaching the community that they can receive something that is powerful and healing from them, from individuals that they may have driven by all their lives, is a breakthrough that leads to new kinds of relationship in communities and an ability to really understand that participation in poverty transformation and serving other people is not about transactions of handing them an energy bar or a sandwich, but it's about transformation. It's sending yourself rather than a bunch of other stuff. If you look at that second slide, and Selena's going to move them for me, we call ourselves a poverty transformation movement. We are learning to translate our vocational and life experiences and personal networks into tools our sisters and brothers in poverty can use to develop sustainability while relationship with them transforms us. When somebody is being served in a wraparound model, they are a client. But when they come into the community, we have a different kind of link, and we want to recognize them through the open table model as all of us as having an equality of humanity. And we follow Martin Luther King's request and reminder that we are our brother's keeper. And so we become brothers and sisters to each other using that terminology. And I think you can see that's really the beginning of a view for what the meaning of relationship can be to people in a community model. On the next slide, you'll see what the challenge is for developing real community and relationship that allows congregations to transfer intellectual, social, and financial capital into transformational activities. There's no model. Many of the people that I'm speaking to now participate in wraparound, are experts in that model, use many other different kinds of models so that we can learn what investment of resources can result in a specific outcome. We can train to that outcome. We can research that outcome, and then we can replicate that model to have more outcomes. Most of the time, models in faith communities to serve the poor are making sandwiches, buying a bunch of energy bars from a big box store, and bringing your used clothes in to be distributed. There is no transformational model that is available to the faith community that allows them to invest in a different way. It's interesting to me in my congregation, I would say, 80%, 70% of the people in their career path have used models, or they design models, they develop models, but for some reason we really haven't seen a congregation or congregations in a community as a system that can adopt a model that can be trained in it so that their personal and community resources can actually link up with government systems and extend the system, and that investment can occur. So a model is definitely the missing link. And when we collided with this man at the shelter and we tried to figure out how to help him move from poverty based on his own vision for himself, all we could really do is start counting the resources in our congregation. Not the money, but the human resources, the educational experience, the skills, the resilience, the relationship and community potential, the social capital that was incredible in our community. But when he came to our congregation seeking transformation, we wanted to give him used blue jeans. We reserved all the intellectual and social capital, all of that knowledge, all of the door opening, all of that hands up, all of that potential relationship we used to build our lives. But we had a different view of what would help him build his life. We did not have a model or a way or training to be able to transfer all of that power to combine with what he was receiving at the shelter to help him move forward into the community. And so we were business people. We didn't have any training in poverty or in human services systems. And for us, all we could think about was, well, suppose our brother had a board of directors and he was the chair, and we met weekly, and we were able to access the intellectual and social financial capital and the relationship potential in our congregation. If we were able to release that to him through relationship, mutual relationship with him, that would work just as well. So out of that experience through a model called Open Table, I think it's so important for the faith community to stand up and for us to say to our government partners, we can provide relationship. We have a vast amount of locked up intellectual and social capital that can be invested for human development, but we don't know how to do it. We don't have the training to do it. We don't know how to measure the outcomes. Could you transfer your experience and your knowledge into this movement so that we can be community implementers that share the same practice values? One of the first people that volunteered to help Open Table and to help us really become a manualized model on a track to develop evidence, to develop a theory of change was Dr. John Vandenberg. John stepped out of retirement. He's an advisor to our board, a consultant to our board and our executive team, giving us about a third of his time. What I find now, such a blessing is to look at the values that are in wraparound and what its best practices are in terms of individualized planning, voice and choice, creating a safe space, a community model. Those are the same elements that grew up independently in Open Table. We didn't know how to recognize them and we didn't know how to measure them. But as you learn more about Open Table, you see that all of those elements are present in the model. Probably the pillars of our theory of change are, number one, relationship, mutual relationship. Relationship develops trust. Trust creates vulnerability. It creates an openness to share intellectual and social capital in a community and natural support way. Voice and choice and creating a safe space. If you were to look at our training that SAMHSA invested in and John and others contributed significantly to, you'll see that when we train faith, the primary core directive is faith isn't discussed unless the brother or sister you're serving requests it. The faith journey on Open Table is about the people who are serving, deepening their faith, finding a real purpose to apply their faith in the community. Shared purpose is another important value in Open Table. It's the idea that we all have different perspectives, we all have different ways of seeing the world, we all have different identities as we serve in the community. But the brother or sister we serve, that young adult, that is the focus that we share. We each bring our unique perspective to individualized planning to be natural supports to that, so shared purpose. Reconciliation is probably our fourth pillar in our theory of change. Reconciliation between faith and government, ending the mistrust, seeing what co-investment can do to change individuals, create sustainability, reconciling to each other, economic reconciliation, racial reconciliation. A number of our tables are next year in systems of care will be shared by African American and Anglo Church members together doing shared purpose work around a young adult in the community. The first young adults who identify as LGBTQ are being served by tables. And I'll talk more about that in a bit. Through a shared purpose, through training, through partnership, through co-investment, the community can begin to really step up to the level that our government and the professionals in it are investing in people, and outcomes can improve. If you take a look at the model very quickly, it probably looks a lot like a wraparound. This for us is a lot like a dinner table, a family coming around to discuss, to encourage, with a difference that this table is a network powerhouse. They're able to network for all kinds of natural supports around the community. I'll cover that a little bit later. People sitting around this table are members of congregations. They could be people who aren't a member of a congregation who've been invited by a friend to that congregation. There's no faith test to sit at this table. We are headquartered in congregations because that's a center of community knowledge, community development, and that has a built-in network to intellectual and social capital. And of course, that's where we grew up as a movement. People sitting around this table make a commitment to serve for a full year. They have 52 meetings. They spend an hour a week in a meeting with a brother and sister. They commit to social integration. So the first man that we helped when my family was going to see a movie, we called him up. There were 10 families offering invitations. People were socializing together. It just became impossible to know who was or who wasn't in poverty, and actually everybody was in poverty of some sort, economic poverty or the poverty of relationship, the poverty of not knowing how to transform their community. Everybody has an office on the table, and you can see key life domains there. But those domains, those people work together on an individualized plan that's directed by the brother and sister. They have the only veto on the table. They use those offices for specialized networking. If a brother and sister has never filed a federal income tax, which could have an impact on a future Pell Grant, the chair in finance is going to network to an accountant in the congregation or in the community to help resolve that and get those taxes filed to prepare an offer in compromise that somebody in poverty may never be able to afford. On the health care chair, if there is a mental health challenge that's not already being involved by our government partner, that chair would contact the system of care for a powerful referral. Every one of these chairs is networking for natural support in the congregation, at the work site, and in the community to bring this abundance of skills and knowledge and services to support the transition of someone. One of the ones that I heard last night, I'm in Saginaw, Michigan, where Saginaw Max is also one of the system care pioneers. Just a young adult speaking to a group about how she received a promotion at her job, but it required her to be there at 5 a.m. every day or 5:30 a.m. every day. Her table members picked her up at 5 a.m. every day and drove her to work and brought her home until they were able to network for a donated car and a donated mechanic so that she could take advantage of this promotion and the higher income. This is the bridging that the community can provide, but without training and without a model and without partnership with best practice, it cannot be activated. If you look at the next slide on the young adult version, Casey Family Programs in Arizona was a great encourager. In fact, they were the convener of Open Table serving young adults with complex needs. Young adults with complex needs are the fastest growing population served by congregations that use Open Table, and certainly our work with systems of care has helped for a lot of intellectual capital and experience and training to flow into this model. Early on, young adults told us that 12 adults was way too much, so this model kind of moved down to more of a family size implementation. John Vandenberg gifted us a study of our 2013 graduates, many of whom were transitional age young adults. And you can look at it on the website, but probably for me, the most significant finding of that study is that after 2 years, 95% of those graduating brothers and sisters were still in relationship with their table members. And so new supportive community with long-term safety net, long-term access to intellectual and social capital is created through a model that government can help inform, help develop training, help to measure outcomes. On the next slide, we were brought by behavioral health experts the idea of using Prochaska's trans-theoretical model of change, stages of change, just to understand where our brothers and sisters are on that continuum so tables can appropriately build relationship. If somebody is not in an action stage, it might not be a good idea now to multitask. It might be a better idea to extend the relationship building. Of course, the brother and sister informs this, but this also helps the team better understand how to build a healthy and productive and safe relationship. The next slide this is just to show you what the locked up intellectual and social capital in a congregation looks like. It is locked up and it is locked away. And if the vault can be opened through faith-government partnership, the resources behind that vault door will never run out. There is no grant limitation to the impact and the investment of those resources in people. On the next page, you can get a look just at some of the elements that tables are able to resource. I always talk about dentistry. I hope my dentist isn't listening, but my guess is over the past 3 decades, my cleanings and cavities have sent him to Hawaii, he and his family to Hawaii a number of times. So I feel empowered to go ask him if he would co-contribute with my faith community in an individualized plan of a human being to see them develop and combine his skills and gifts with our skills and gifts to create true transformation. You can find these supports being accessed by every table. This is not the challenge. Congregations and people networking for natural support is the easiest part of the model. On the next slide, Open Table is being practiced right now in about 20 states. Don't think that we're too big. We've had about 400 tables. Our implementation in some of those states is just beginning and small. Open Table is an organic movement. But one of the things that I do want our government partners to know is that we are a licensed model. Congregations sign a contract. They must contractually adhere to the practices in the model. They must learn and focus on fidelity. So there is a real control, and partnered with our government systems who can participate in training, but also be a resource for all of the things that a congregation may not know, but an inviting and convening resource. Probably one of the most powerful things that I see in the faith-government relationship, and I've seen this in systems of care, is after a training, a system of care leader passes out their business cards to the people on the table and says, if you have a systems question, if you need a referral, you can call me directly. So all of a sudden, that fog about who would I call, how would I find something, government's opening up its intellectual and social capital to the faith community in a reciprocal way. Just on the last slides, as I said, Wraparound Orange is one of the 3 Lewis and Clark systems of care. There are number 3 more on board, and we hope more will be next year. You can see their belief that there is no single organization or model that can solely and uniquely support the development into human potential of a young adult or an adult. Follow the steps for building a movement. This takes time. So this is not an overnight development. In the same way that implementing a system of care takes the building of an infrastructure and training and people and learning a model so that it can be replicated and serve more people, the same holds true for the implementation of a new system in faith communities. But once that system is installed and we train a faith community to implement, then we can begin to develop larger and larger amounts of tables. You can ask us or contact me about the match potential of tables. Tables in measured volunteer time contribute about $16,000, not including the financial capital, the goods and services that are invested just during that initial year-long process. Recognizing the challenges, boy, I think that's significant. Probably the biggest challenge is faith and government trust. And we've developed a training now that has been implemented twice, bringing systems and faith community leaders together for 2.5 days to learn this model, but to work together to start to develop their plan together but most importantly through exercises in small groups, the kind of relationships so that they can see that they can call each other and on an equality basis solve problems and challenges together and implement this model. I am so excited about the faith-government partnership. I am so thankful to SAMHSA for being willing to look at the community and say, there's a better way, and to see that the same values can be prospected in systems of care and the community through training, practices, the exchange of information, and measurement to be able to expand that significant investment in human beings that you all are making. I just invite you to contact us with any questions. If you'd like to speak to a project director around the country implementing this, call anybody I've named. Please learn more, and please think about the potential of this new partnership. Thank you.
Thank you so much, David and John, for such transformative and useful information and sharing your models with us today. We have about 9 minutes left on the call, and we'd like to open up the chat box for questions from any of our participants on the call today. A couple of people are typing. It says, great presentation, John. It's Chris, is it Minnick and Judy Davis from BHARP System of Care, Pennsylvania. Looking forward to meeting you on October 20th in State College, Pennsylvania. Please bring this PowerPoint.
Hey,
Wonderful.
Brother and sister.
Right, we have another person typing, Natasha Byers. While Natasha is typing, Colin, if you could go ahead and put up our first open-ended statement for our participants. So we have a couple open-ended statements that we'd like for you to respond to. This statement is from a faith leader perspective. So we'd like for our faith leaders that are on the call to respond to this statement. I hope that behavioral health providers understand that, and fill in the blank. So if you could type your responses, that would be very helpful for us. Okay, well, while we're waiting for responses, we have a question from Natasha Byers. It says, I really enjoyed the webinar. Question for the presenters. Our system of care grant is not focused on faith communities, but on building system of care for young children. We have monthly meetings in 3 different cities, and I'm wondering where to begin in engaging faith communities when we don't have the resources to take on the fullness that was presented here. So Natasha, my recommendation is that incremental change is always the best way to go. And so identifying key faith leader champions in your community would be a great first step. Individuals that may be passionate about behavioral health in young children, but that are also very active in the faith-based community network. And then also looking for established existing interfaith networks that may already exist in your community and getting on their agenda and sharing information about your system of care grant, and then identifying aligning goals, ways that you all can work together in meeting your grant goals. So I would start with identifying champions and finding existing interfaith networks. Thank you so much for your question.
Selena, could I add to that
yes,
in faith-government partnerships, with a community organization or 501c3s that a number of faith communities have, the faith-government collaboration, to me, is one of the most powerful things that we can bring to community foundations and local foundations. Community and local foundations get the same counts from their grantees. The local nonprofits that we've served many people, but we have no data on transformation. And so bringing a transformational model that shows cross-community collaboration, that extends the system of care, that brings in best practices is appealing to community foundations and local foundations as well as statewide foundations that might invest in those counties. So I think it's really important for us as a partnership to start influencing the flow of charitable foundations and their perspective. The more that we can do that, the more they're going to raise the bar to the system of care bar and look for measurable transformation in outcomes. If those billions of dollars could flow into transformation in a community rather than thousands and thousands of transactions, that would be an incredible outcome for this kind of partnership.
David, I think you wanted to add to that?
Sure. There's times that I think that it can also just be helpful. I like stealing the suggestion as well of the interfaith connections if you have a group like that in your community. But I think parachurch organizations can also serve as a good resource at points just because they may already have established relationships with individuals from those congregations. It may be clergy who they have those connections with, or it may just be leaders within those congregations as well.
Okay. All right, thank you so much. So we have a few responses from our faith leader perspective. Some of the responses include partnering. I hope that behavioral health providers understand that partnering with faith-based communities builds trust, transparency, and the transfer of information with families and congregations. Wonderful, well said. That local faith-based organizations may not know who you are and what type of clients you work with. Go visit them. They need referral resources. Absolutely. That was a key message in our presentation, is the importance of those referral networks and knowing when and where to refer and what the referral process involves. I hope that behavioral health providers understand that religion is my specialty, all right? And then also understanding that faith-based communities can be a support in terms of providing behavioral health services. Thank you all so much for your responses. We're going to go to our next open-ended statement. This is from a behavioral health provider perspective. I hope that faith leaders understand ... So I hope that faith leaders understand what. So feel free to type in your responses. We'd love to hear from you. And you're welcome, Natasha. Thank you for your question. Okay, our first response is, I hope that faith leaders understand that we can and want to work together. And I think that's an important verb there, that we want to work together. We want those collaborative relationships so that we can maximize optimal well-being for our children, youth, and families. Absolutely. Any other responses? All right, well, we thank you for your participation. One other response, we are available to provide support and education, absolutely, so that mental health literacy is a critical component in terms of working across and building that bridge between behavioral health providers and the faith community. Another response, that your government partners very much want to connect with you, but don't know which of you are truly open to destigmatizing mental illness. Okay. That's important, that we want to make sure that we are spreading the message that recovery is possible and reducing that stigma through various programs, various educational programs, such as Youth Mental Health First Aid, QPR, Question, Persuade, Refer, Adult Mental Health First Aid, and so forth. All right, we have 1 minute left, so we'd like to jump back to the PowerPoint just to share a few resources. We do have have office hours next Thursday from 1 to 2 to further the discussion, and we'll be sending out that information as well. Our contact information is here in the PowerPoint, and we also have various resources that will be helpful in building that bridge and linking the faith community and behavioral health providers. We thank you so much for joining us on the call, and we look forward to you joining us in our office hours next Thursday from 1 to 2. Have a great afternoon.